All right, everyone. Well, good to see you. Hopefully you can hear me good. Let me know if I need to shout into this microphone anymore. But we're going to jump in this afternoon and sort of demystify the world of pathology for many of you, hopefully. I don't think most people actually meet their pathologists these days, so it's kind of like a little bit of a unicorn maybe. So it's good to see. And we don't get to see you guys very often either, so that it's a mutual. Good to see you guys. And thanks for the invitation to be here and share with you some of the sort of background or things that happen between surgery and a diagnosis. There's like a whole world that goes on back there. Discussions, maybe some fighting over diagnoses, things like that. Not as dramatic as The Bachelor, but maybe sometime we have our moments too, right? So we're going to jump in today. Let me just kind of give you guys a sense of how this will work. I got maybe about 20 slides or so, and then as you probably have noticed, there's some little like sticky pads on the wall. And what we're going to do is sort of make you all honorary pathologists today. And good or bad, I'm not sure, so we'll find out. We're going to kind of work with you to, I've got some cases here of reports, and what we're going to do together in groups is come up with some integrated diagnoses where we take the stuff we see under the microscope, the stuff we get from the molecular testing, and we're going to put it together and come up with our diagnoses for patients. And I think this might be the best way to figure out how this all works in the real world. And the cases I've selected today are pretty typical, very standard cases you'll see as part of a neuropathology service. And I think you'll see how all the pieces come together and where there could be, and we'll have time for questions, and I'll be circulating around. And I see Dr. Sengupa back there, and I see she's floating around too. So she may, I've roped her in to help me a little bit, but it'll be fun. Part of it is for you to understand, like, what happens, how do you get to a diagnosis? Because I think we all sort of, a diagnosis will happen, okay, but how and who's doing it, and how do I know it's the right one? I mean, has anybody ever asked yourself, like, how was I diagnosed correctly? Because everything seems to come from that diagnosis, all the treatment plans. But what if there's a debate behind the scenes, and it could be different things? How do we work that out? How do we communicate that to the oncologists and the surgeons and everyone to sort of navigate these? And I wish I could tell you it's all very simple and always straightforward, but we like to say, there's this book that's published that has all the different types of tumors, but we always say the tumor didn't read the book, and it didn't know it needed to fit into one of the categories, and so we always end up with these complex cases, and it's something we have to think about, but that's where we tend to keep it in the background. But it's generally pretty straightforward, and I think the teams work together well: surgeons, oncologists, and pathologists and radiologists. So with that, let me introduce myself. So Shak Ramkissoon, Dr. Shak, or you can call me anything. My son these days refers to me as Bruh, which is apparently short for even bro. So I thought bro was short enough, but apparently not. So he's 10. So we'll see. Started fourth grade. So a little conflicts in there, and then, okay, here we go. So let's talk about, I really wanted to start at the beginning because I think that's where we're most comfortable with, right? So a patient will present with some type of symptoms, and we heard from our speaker at lunch that he presented, I think, with seizures as his first sort of presentation, and that's pretty common. And at some point, if, depending on what type of presentation your symptoms are, you should get routed to a physician or a doctor or a nurse or someone that says, we should get some imaging done. We need to get a kind of a view of your brain to see what's going on in there. Sometimes, as you may or may not know, that could be a long time, a short time, depending on the symptoms. But eventually, you should get imaging. And at some point, the radiologist will get a report. And she'll be looking at that result and saying, hey, okay, what is this? What could it be? Just like we learned at the tumor board, there are lots of different types of things that go on in your brain. And so the question is, which one is it? And imaging, neurology, neuroradiology, they're really good. I mean, it's evolved so much. It's really quite spectacular. But even still, there are still difficult cases where the imaging features overlap a little bit with other things. And so we're never going to treat it, or we certainly try to not treat patients based on best guesses, right? It's like you have to know what you're treating before you start treating. So that leads us to surgery. And this is where our neurosurgical colleagues come in, because the question is, okay, we have to sample this. We have to sample it safely. What is the plan here? Are we putting the needle in and we're pulling out a few cells? Are we doing a tiny biopsy, or are we going for a gross total resection, right? And it depends on the tumor, and it depends on the patient and location and sort of the safety profile around that procedure. But once that tissue comes out of the patient in the operating room, something happens. It goes from a surgery to a diagnosis. So how does a biopsy become a diagnosis? That's today's sort of what we're going to be talking about. And I think most of this, I think patients don't see. They just are, I know you guys are always waiting. You're like, what is the result? Am I getting the result? That's usually it. But there is a team of folks in the background working through that process. And some of it takes time, like you literally have to let the tissue process overnight. You have to do stains, and some of this adds time, which I know is extremely frustrating. But we have to be right. We don't get the option of pulling back or switching diagnoses. Once we issue the diagnosis, that's generally it. And oftentimes, nobody ever says, like, a second opinion, which I always recommend. For pathology, too, you can send it to someone else and have them look at it, too. But most of the time, that doesn't happen. So we want to really make sure we're certain. Okay, so what is pathology? It's always like a weird term, right? There's a lot of weird shows on TV. You could see pathologists, and they're doing all sorts of things, but most of us don't do any of those cool, fun things. Most of us are working in the hospitals or at a cancer center, and we're really just focusing on understanding, taking the tissue or any kind of body sort of specimen, blood, saliva, urine, anything, all those stuff that you sort of routinely have done, it's all signed out and reviewed by pathologists. Now, once that tissue leaves a patient's body in the form of a biopsy or a resection, it goes to a pathologist eventually to look at it. And our job is to look at it and say, well, what is it? Is it a tumor? Is it not a tumor? If it is a tumor, what kind of a tumor? If it's not a tumor, well, what is it? Because you're waiting, the treating team is trying to figure out what to do because you came in with some symptom and they had to biopsy something. So what is it, right? That's usually our process. And so that's what most of what we end up trying to do is, how do we just come to a diagnosis that can allow the rest of the process to take place in terms of managing that patient? And pathology can be largely broken down, or at least in my simplified world, into three phases. There's like part one or phase one, which is during the surgery. And we talked a little bit about this during the tumor board, but this is something called like a frozen section. And while the patient is in the operating room on the table, the surgeon will typically send out a small sample of the lesion. And the part of that, where it goes is there's like a little room typically next to the operating rooms called the frozen section room. And that's where the pathology team hangs out. And we will take that sample and look at it under the microscope very quickly and call back into the room and sort of let them know what we see. But that's the first sort of interaction with pathology you probably have for most of these sort of brain tumors. The second is after the surgery ends, what happens to that tissue? It goes off to some place to turn into slides, which will turn into a report. And then, so that's sort of phase two. And then phase three is when we actually look at the glass slides and try to interpret them, read them, just the way a radiologist reads, sort of those black and white, very difficult for me images. We can look at the pink and blue ones and say, oh, okay, I can make something out of this. And so that's part three. So let's talk about phase one, this sort of interoperative thing. So once the surgeon is in there, when the patient's in the operating room, the surgery begins. The surgeon sort of opens up the lesion, right? They open up the skull, and they'll have access to the tumor. What'll happen then? A small sample will come out. It gets walked over by one of the OR staff members to like the next room over, or 2 doors down, or something like that. And we just get like this little piece of tissue, and this is a machine that is kept super cold. It's like at minus 20 degrees or something, and it's just about the size of this podium. And what we do is we kind of like snap freeze or very quickly freeze that tissue. And then what we do is we just like start cutting very thin slices of the tissue off. We put it onto some glass slides, like here, and then what we do is we just look at it right under the microscope, right there while the patient's in the operating room. And so sometimes the surgeon comes out, she'll sit with us, we'll all look at this, look at the cases together, or sometimes we'll just call into the room once we sort of had a sense of what we see on the slide. But it matters a lot because we kind of alluded to this during the tumor board. If we look at the slide, it's presumed to be a glioma. We look at the slide during surgery, and it looks like a glioma. Then I'll call back in and say to the surgeon, hey, I think this is a glioma. It looks high grade. And then they'll be like, okay, we'll continue with the resection. And so they'll try and do as much of the surgery as possible. If I call in and say, hey, I know we thought it was going to be a glioma, but it kind of looks like lymphoma on the frozen section slide. Are you sure this is, how does it look in the surgery? Does it feel different? Does it look different? All these kind of things. And they'll say like, yeah, it didn't quite look like a glioma, but anything's possible. Well, I'll say, well, on the frozen section slide, it looks like a lymphoma to me. And so right there, they'll typically just stop the surgery, back out, because the treatment for lymphoma is not surgical resection. It's chemotherapy, radiation therapy, these kinds of modalities. So the surgery will end, and then the sample will be sent off to pathology for further workup of that lymphoma diagnosis. So that's the first sort of part of pathology, and we oftentimes intervene right there and can redirect the surgical procedure. Sometimes it's demyelination event, it's MS, multiple sclerosis. Sometimes it's an infection. I've literally seen parasites in the brain that are mimicking a brain tumor. And so those, again, you're not biopsying those, you're going to treat those with like anti-parasitic medication. So there's a lot of things that can happen in your brain we don't typically think about, but they present differently. Okay, so the surgery's ended, the tissue's sort of all put into a little cup, and it gets sent off to the lab, pathology. And so once it comes into pathology, this is kind of like phase 2 of the process. And we spend all of our time here processing and preparing the tissue to look at it under the microscope. Because you can't just take this piece of tissue and just sort of look at it under a microscope. You have to do all this manipulation to it to be able to cut it, section it, and then stain it to be able to look at it under the microscope. Now, the first thing we do is once we get it, we just sort of do something called a gross description. So if you ever look at a patient report or your report, you'll see a section called the gross description. And it's not fancy, basically is we open the container, we take it out, we look at it and say, oh, what does this thing look like? And quite literally, I'll just kind of read you guys this one. It says, the specimen is received fresh. So what does that mean, fresh? Well, it's not frozen, and it's not in some weird fixative or anything. They literally just took it out from the patient, put it in a cup, and sent it to me. So that's about as fresh as you can get. And then it'll have like the patient's name and things like that on the container. So we say, okay, it's labeled with the patient's name and it's the right brain biopsy. So we know where they got that sample from. Because if a patient has multiple lesions, they may send multiple cups. We want to be able to track each cup to that sample and make sure we can like tell the surgeon and the patient what each of those biopsies were. Okay, so then I'll say, well, now I just kind of describe it, right? The specimen consists of a single one piece of tissue, irregularly shaped, because it's kind of like, it's like a brain tissue. It's very gooey, and it's like Jell-O to some extent. It's tan, it's white. I touch it, it's soft. Sometimes the tumors are like a rock-hard lesion, like a glioblastoma. Or they're very calcified, and you can feel it when you touch the tumor. So soft white tissue fragment, and it's measuring, I give some dimensions, 2 by 1.5 by 0.5 centimeters. And I say like, oh, it's got some hemorrhage, and that's probably just from the surgery. When you cut these little blood vessels, they bleed. But that's my gross description. So now I know I got about a 2-centimeter piece of brain tissue. That's what it looks like. And I will submit the entire thing in one cassette for processing. So that's the first phase. So it kind of goes into a cassette, which is kind of the next thing here, which is this sort of little container. We put it into the cassette. That cassette goes in a machine overnight, and it sort of adjusts the tissue, pulls out certain like water kind of stuff out of it and puts in different sort of reagents. And over time, it kind of preserves the tissue. So it's a formalin-fixed sort of preservative. And it fixes the tissue, prevents it from degrading. Because once it leaves your body, it kind of starts to degrade. So the goal is to preserve it as much as possible. So that's formalin fixed, and then kind of sits in this little cassette. And then the next morning, after it's been through that process, we embed it literally in a wax, paraffin wax. And so if you ever hear the phrase formalin fixed, paraffin embedded, or FFPE, we're referring to a patient sample or your sample or a block. That's what it is. So that's the FFPE block at the end of the day. It literally is a chunk of tissue, gets put into this waxy material, and then the next day what happens is once that's done, we cut it. We just kind of shave off little sections of it. This stuff is not new. It's been around like 100 years, right? So it's very cost effective. It's very standardized, and people do this all over the world. You don't need to be very fancy to be able to do this kind of stuff. Once the pieces of tissue are cut, they're put on a glass slide and they're stained. And now we have them on a glass slide with our favorite colors, pink and blue, H&E stains. And what we do is then we're able to look at it under the microscope. And so that gets us to phase 3, which is what is my diagnosis? We finally have a slide. I can look at it under the microscope to issue a diagnosis. And the question you should be thinking is, how do you know that the diagnosis I get here in Chicago is the same diagnosis I'm going to get in Seattle or New York or the UK or Beijing? Like, how do you know, right? I mean, I can have my opinion. Everybody can have our opinion. So the way we do this is there's this standardized sort of classification system we all use around the world. And you'll hear this World Health Organization or WHO grade. And it's literally a book. Like a book is published every few years. It's like the pathologist's Bible, right? And we have that book, and it comes out. And within that, there's a description of every tumor type. What are the features you need to see for that tumor in order to diagnose it as that tumor type? So that if we're both looking at the same tumor, we should both come to the same consensus diagnosis. And so the trick here is that it changes over time. So when we talk about evolving molecular classification of brain tumors, a lot of the stuff we talk about today didn't exist, a few years ago. And prior to 2016, there really wasn't even much molecular classification of brain tumors. Now it's like the pendulum has swung the other direction. It's almost all molecular subtyping now, right? You can't really, or you really shouldn't be issuing diagnoses if you don't have some form of molecular data. So that's how we all sort of get to the same point, so that we all are diagnosing a GBM or an oligo or anything like that very consistently. Okay, now once I have the H&E, I start looking at it, and I'm like, okay, what do I see? Now I've been staring at H&Es for a very long time, so it's pretty straightforward for me, but I know for many of you this is kind of weird, right? It's these little purple things are the tumor cell nuclei. So the nuclei stay in this purple color, and the rest of the parts that are not nuclei stay in this sort of pinkish color. So the H is hematoxylin, which is the purple, and the E is the eosin. So those are the two stains. So when we say look at the H&E slides, we're literally talking about the two color slides. And so once we have this, I start looking through and say, well, okay, what is it? And I say, well, first of all, there's too many cells in here. Why are there so many cells? My brain shouldn't have that many cells, I can tell you. So there's too many cells going on here. They have kind of weird shapes. And you know that by looking at normal brain to figure out when it looks different. And then I say, well, okay, is it a tumor or is it something else? And right away I say, like, well, there's too many cells in here. It doesn't look like inflammation. It doesn't look like a parasite. It doesn't look like infection. I don't see a demyelinating event like MS. And so right away I start thinking it's some sort of a tumor. And so I start going down, well, what are the tumor possibilities? Oligo, astro, ependymoma. Is it a brain metastasis? Is it lymphoma? Is it a DNET we just heard about from our speaker at lunch? Right? There's all these different things it could be. Now I got to figure out, how do I get from this big list to one diagnosis that everybody agrees on so that the treatment plan can be developed around that diagnosis. Now, as I look around, I will also be looking for things that are high-grade features. When we say high-grade, you'll oftentimes hear low-grade glioma or high-grade glioma. Generally speaking, and don't beat me up on this one, but if it's grade 2 or grade 1, we definitely say low or lower grade. And if it's a grade 3 or 4, we generally call it high grade. There's nuances here, but for the most part, that's generally true. And if you're looking at a glioma sample, and you see these cells that are actively dividing, where they're like mitotically active, we literally caught them in the middle of turning from one cell into two cells, then we know that's a mitotically active tumor. These are the kind of cells that will be responsive to radiation therapy or chemotherapy because they're actively dividing, so they're taking up the chemotherapy. There are these also crazy-looking blood vessels, which we call microvascular proliferation. When you think about blood vessel, it should just be like a tube, right? Blood should just be kind of going in and out. But what is this weird, like, sort of cul-de-sac looking thing over here? This doesn't make any sense. So this is completely abnormal. You shouldn't have this in your body. But this is what the tumor does to try and pull in more blood vessels to help it keep growing and growing and growing, because the blood brings the oxygen, brings the food. So the more sort of supply chain it can bring in, the bigger it can grow. So that's what it's trying to do. And when it runs out of food and oxygen, sometimes it actually dies because it becomes necrotic. So in this area here, you see like viable living tumor cells because you could see the nuclei. But in this space in between, it's very pink. You don't really see nuclei because it's all necrotic tumor. The tumor cells died off, the nuclei blew up, and you just have these areas of what we call pseudopallidating necrosis, which is very diagnostic of a glioblastoma. So this is what's going on when we're looking at these. All these things are going through our head. What tumor type is it? What grade is it? Is it high grade? Is it low grade? And these kind of things. We also do a fair amount of lab kind of testing, something you'll maybe hear more about or have heard about or seen on your reports around immunohistochemistry. So this is just, again, another fancy term. We're trying to see what proteins the tumor cells express. And if it's brown, it means it's expressing it, and if it's not brown, it doesn't express it. So when you look at this slide, these are different markers we look at, like GFAP, OLIG2, P53, IDH, R132H. So these are proteins we're looking for, and depending on the patterns of the proteins, we can help put it into different lineages. So right away I say, hey, this tumor cell is pretty brown for GFAP, it's pretty brown for OLIG2, and it's pretty brown for P53. So it's P53 positive, GFAP, OLIG2 positive. To me, that really fits with an astrocytoma. So I've kind of ruled out the other tumor types, and my differential diagnosis is starting to shrink down. Now I'm an astrocytoma, and I'm thinking about grade. Is it low grade? Is it high grade? Well, I didn't really see a lot of mitotic activity. I didn't see other things, so I would say so far it's a low grade astrocytoma. And this antibody picks up the mutated form of IDH. So now I know it's an IDH mutated low grade glioma with a low grade astrocytoma. So we keep sort of gathering more information, and we put that together to come up with a diagnosis. But the microscope gets you so far, and about 10, 15 years ago, we started moving more and more into molecular subtyping. So when you hear the word histology or pathology, microscope-related activity, that's like part one of the pathology, like when we're kind of working up the diagnosis. And then we go to this world of molecular testing. And now, over the last few years, we've really expanded the types of modalities or technologies that we can use. Some of the more historical ones are like FISH, or fluorescence in situ hybridization, where we look for certain deletions or fusions, things like 1p19q co-deletion, where we'll see that in an oligodendric glioma. You could typically do that by FISH. You could also do it by microarray as well. Now today, I think generally speaking, we try to sequence every brain tumor because we're looking for those IDH mutated tumors, because now we have targeted therapies against some of these agents. Same with BRAF, same with EGFR, PDGFR. There's different clinical trials, and you need to know the mutational profile of the tumor in order to get onto some of those trials. So these are all different technologies, and the most recent one that it's mentioned a little bit in the current molecular classification of brain tumors, but the next version of that blue book that comes out in about 5-7 years, you're going to see it's probably going to be heavily focused on methylation profiling. So when we have this conference after that one, we'll be talking more about the methylation signature of these tumors in a way that we're talking less about it today. But this is part of our evolving world of brain tumor diagnostics. Now, once it's all done, what we're going to do is put it all together. And this is typically what's happening in the background. We'll take all the things we saw during the microscope sort of review. We were kind of like, it's an oligo, it's an astro, but I don't see mitoses, I don't see vascular proliferation, I don't see necrosis. So I'm going to call it a grade 2 sort of oligo or astro. So I typically would say it's a grade 2 glioma. Then I would do my stains and molecular workup, and I would say, okay, now I have some more information. It's negative for 1p19q co-deletion, so now I can say it's not an oligo. It's probably an astrocytoma. And then the mutational profile of P53, ATRX, and IDH, or the different genes that are mutated, sort of is like the genetic signature or fingerprint of an astrocytoma. So right away I'm like, okay, I know how to diagnose this patient. This is an IDH mutant astrocytoma, WHO grade 2. And that's what I type into my report. And I put some of the comments down below about how I got to that decision. I'll typically do an MGMT promoter test because that's important for trying to decide, maybe with temozolomide or not. And I write up a little note around like how the patient presented and finalize the report and send it out. And it goes off into the system. And my neuro-oncologist colleague would stop calling me, and my surgeon will stop calling me. But this way, once they get it, we will oftentimes discuss this case at tumor board as well. And we would say, here's how I came to this diagnosis. And then just like in the tumor board earlier, we can figure out now what's the plan. How are we going to treat this? Do you want to use a targeted therapy, TMZ, radiation, or some combination? And that sort of depends on the clinical team and how they want to manage the patient based on their individual circumstances. Okay, so let's talk a little bit about the report itself. Sometimes these reports they're all very difficult to read, so that's, I'm sorry about that, but they're oftentimes just like, sorry, go ahead, yeah.
Just a quick question. So on the report section, it says pass. Does that mean you have or you've done it? What is that in general mean?
Say that again? It says passed?
Pass, P-A-S-S, so like when your biomarker.
Oh, like if it says passed, like, it depends. Like, the reality is if it's ambiguous on the report, somebody didn't do a good job writing the report. That is exactly the problem. So we've tried to standardize language, but people use different phrases and terminology, and oftentimes it's like if you say something like no evidence of mitoses versus there is no evidence of mitoses, or mitoses are not identified, right? You're kind of saying the same thing. But if somebody reads it quickly, they'll say, oh, mitoses are, and they'll not read the end of it, and they might think, oh, mitoses are there. We're saying, no, mitoses are not identified. So a lot of it actually comes down to actually reading the reports, which in medicine is sometimes a little bit tricky, but what we're trying to do is keep these reports as standardized as possible so that we don't have so much ambiguity. But if you have something you want me to look at too, I'm happy to do that as well, yeah. But this is generally like a format of a report. We typically have the patient's sort of demographics, we call it, the provider's name up at the top, and then a little bit about the history. Most of the time when we're looking at the pathology, there is very limited history, right? The patient may have come into to the emergency room, got routed directly to the OR, they're getting a biopsy, and all we know it's a patient with a seizure, and that's it. We don't know anything else about the patient because nobody else really does either. We know where the procedure was done. Is it on the occipital lobe? Is it in the frontal lobe? Is it in the spinal cord? So the surgeon will tell us that. And then we have a frozen section diagnosis. Sometimes we'll transcribe that here. And then we should have the integrated diagnosis that kind of pulls everything together, followed by a comment. Usually it's a comment that we would write so that another pathologist or the clinical team looking at it, it's sort of like our inside baseball commentary about what we saw. Because if you go to get a second opinion somewhere, you may bring your path report with you. They're not going to call me. They're not even going to know who I am. But if I do a good job writing a nice report for you with a nice comment, the oncologist or whoever you're seeing anywhere else in the country can just look at that and say, okay, I read their note, I kind of get what they saw, and I see their final diagnosis, and now I got it, right? So you don't necessarily need to call me if I do a good job writing a non-ambiguous note. And then the gross description we saw before will just get transcribed over. And so this is kind of what it looks like, right? We would say the patient's name, the surgeon or the proceduralist name, whoever sent in the sample. We'll put as much as we know about the history of that patient, followed by the location. The frozen section diagnosis, as far as we got, it was a glioma of some kind, I don't know what. We have our final integrated diagnosis, and then this sort of comment that tells about all the different things we did. And then this gross description about what we actually received, and then you'll typically see who signed that report down at the bottom there. So that's typically your pathologist. You may have multiple pathologists. Somebody signs out the molecular report, and then somebody who signs out maybe the sort of H&E slide part of it, and typically somebody will pull it all together into what's considered the integrated report. So with that, I'll pause here before we get into our group activity. Let me see if you guys have any questions. Go for it, yeah.
Are the samples saved, and how long are they saved?
Yeah, so once they get into that block, that FFPE block, they are essentially good for decades. It's like preserved for life. When I was at Boston Children's, we had cases that were like 80 years old from like the original days of Boston Children's. As long as it's stored correctly, you can just cut new slides and stain it, do research off those samples if it's allowed by consent. And then the other thing is there are some guidelines along like regulations around how long you have to keep a sample. And I think it's typically 10 years, but if it's a New York State sample, it's like 20 years or something like that. So we have literally rooms filled with all of these blocks, and the glass slides too. So and we keep them for a very long time because as patients move around, there may be a clinical trial you're trying to access. We want to make sure that block is available in case we need to send it to a central site for the trial.
And can you state that question one more time? For those that have questions, I'm going to bring the mic to you, and I need you to speak into the mic because this is to also provide a clear audio for those who are joining us for the live stream. They won't be able to hear you without the microphone. So just, he answered it. You answered it, Dr. Ramkissoon. So just state the question again.
Well, I just asked him if the samples are saved, and if they are, how long are they saved for?
Okay. Next question. She had your hand up first right here.
Hey there. So I've been diagnosed with low-grade glioma, not easily classified, NEC, and I was just curious if you had any is there other pathology I can maybe have done, or in your experience, are there certain facilities or pathologists that have experience with not
Yeah.
easily classified?
Yeah, and that's a great question, and it's not that uncommon because, like we talked about, some of the tumors, they show all the features you need to classify a certain tumor into a certain category. And some of them, they don't really know that they're supposed to follow the rules, and so they have varying features, or they look very different than anything we've ever looked at. And so I can't just call it something, because it sort of tells the oncologist that this looks exactly like this type of tumor. So I do have to sometimes be a little bit vague about saying, okay, it's a low-grade glioma, that I'm sure about. It doesn't fit into any of the sort of existing categories. And the reality is, though, we should make sure their molecular testing was done. There was something, that idea around methylation profiling, to be able to see a lot of, the methylation profiling allows you to see the different subtypes of tumor based on sort of like a genetic fingerprint. So I would say, depending on when you were diagnosed and how long that's been, we should look at the molecular workup for that tumor, because you can only go so far based on just an H&E. Just gets you so far. You need all the molecular data now to be able to do this integrated diagnosis, and that's pretty standard now. So I say we should think about what additional data we can get to help put it into a more defined category, if possible.
And how would you suggest going about getting, like, pushing for that data, or like where to know where to go for that?
So I always say start with your oncologist. They're usually your best advocate. And they will either be able to direct you into the, because today that test is probably being ordered routinely. So one, to make sure you get that testing ordered. And then second, if you need help interpreting it, you can even just call your pathologist. They'll probably think it's kind of weird that you're calling them, but they're happy to talk to you. Yeah.
Okay, great. Thank you so much.
But stick to your oncologist. Usually we try to direct everything through your oncologist, so you don't have too many mixed opinions coming.
Right. I don't know, maybe I need to switch oncologists, but I've just been, learning more about this, and it's tough. I didn't even know there was extra, like, other testing that I could have done.
Yeah.
So
Well, the
that's why I was
reality is,
curious.
and not to sort of diminish this, like maybe this gap, but a lot of these diagnostic have only come out in the last couple of years, right? The last edition of the WHO, which was like a couple of years ago, and prior to that, they didn't really it didn't necessarily require all these molecular tests, and now it more and more is. So for patients with like great survivorship, which is great news. In fact, when we look back at their original diagnosis, and we may have said they were an oligoastrocytoma, in fact, that category doesn't really even exist anymore. Now it's either an oligo or an astro, and this sort of mixed category has kind of gone away. So even the diagnosis people have had over the years is starting to change.
Okay, great. Thank you so much. I
you.
appreciate
Yeah.
it.
I have two related questions. First, in the course of either the initial evaluation or through the tumor board review process, do multiple pathologists typically put eyes on the tissue themselves and kind of come to a collaborative consensus on what the tumor is?
I would say depends on the case. Some cases are very straightforward. Like, unfortunately, we look at it, it's got all the classical features of like an older patient with a high-grade glioma, and all the features, like it read the book, and it's like all the features of a glioblastoma. And then even when I do the molecular fingerprinting, the fingerprint is like essentially diagnostic of I don't even need to sometimes see the H&E. I can just look at the molecular fingerprint and know it's a glioblastoma. So in those cases, we oftentimes have consensus conferences where, believe it or not, there's like a microscope with like 14 or 16 heads, meaning like there's 16 people sitting around a big giant table with a microscope, and one person is putting the slide on, and everybody's looking at it all at the same time. And so those are oftentimes called consensus conferences, and we show probably the most difficult cases there, or we're not sure, like, okay, this has it doesn't have enough features to call it grade 3, but I'm worried about it. It doesn't look like the very bland grade 2 kind of a tumor. So technically, based on my WHO criteria, I can't call it a grade 3, but I want to write a note to my oncologist and radiation oncologist saying, okay, technically it doesn't fit criteria for grade 3 anaplastic high-grade glioma, but I'm worried about it. It seems really dense. The atypia is really profound. So like if you're going to follow with imaging, don't do every 6 months, maybe do like every month to start with, just to make sure. And this is the kind of stuff we would talk about at Tumor Board, where it's all these nuances you have to sort of describe to your oncologist and surgical colleagues. But I think there are consensus conferences. And then if you're ever in doubt, you can literally package up the slides and ship it to someone else. And when I was up in Boston, I literally just did consults. All I would do is just get cases coming in and just look at cases from around the country and look at all the existing H&Es, all the existing reports, and then write up my own diagnosis based on that. And like, I would say the vast majority of the time, very little changes, but it's to make sure there's consistency. And then and sometimes I would upgrade, downgrade, or even change a diagnosis. So that's where sometimes a second opinion matters a lot on the diagnosis too, if it's a very complicated case. And the way I'll tell you if the note is really long, it's a complicated case. If it's a very short note, it's typically, we're able to come to a very straightforward diagnosis based on the existing criteria.
And I'll piggyback off of that for my second question. How can you help guide caregivers and patients to advocate for a second opinion on pathology in those complicated cases?
So I think oncologists, they're usually pretty good about this. I think you can ask, like they will even say, and like you can ask Soma too in the back as an oncologist, but we often recommend having a second opinion, just like we talked about Tumor Board, right? Whether it's a surgical opinion, an oncology opinion, a radiation oncology opinion, same thing with pathology. And if you have any concerns, you can always ask talk to your oncologist and say, hey, like, how sure are we about this? And they're like, oh, we're like 100% certain. But it doesn't mean you still can't get a second opinion. Just because I think I'm right doesn't mean it can't hurt. It can't hurt to get a second opinion. So I always recommend if there's ever doubt, like we're talking about a case where it's an ambiguous diagnosis, it might be worth getting a second opinion, right? Just the same way if you went to any kind of doc and they kind of gave you a non-specific kind of diagnosis, you would say, oh, okay, well, I guess it's complicated, but okay, is there an expert in this area? Is there an expert in low-grade gliomas I should send these slides to and have them look at it? Maybe I can get a second opinion that way. And the pathologists or the oncologists, surgeons, and pathologists, they're all talking, this is sort of a standard thing. And so what you do is you say, hey, where should I send this? They'll even recommend, oh, this is like the expert in the field for this type of tumor, you should send it to this person. There's a few of these kind of people that exist in the system that are like, everybody can have an opinion, but once this person sort of declares it, this is what it is. Because we all know, like, there's not going to be, we can all debate this forever, but there's a patient waiting, and we got to figure out what to do.
I was diagnosed with glioblastoma in 2018, and then actually last year at the conference, one of the researchers reached out to me, and he was like, I don't think it's glioblastoma, I think it's DMG, and that was based on like a marker that my tumor had. So what does that really mean? Like, what's the difference in DMG and glioblastoma? Is it the same thing?
So I think so DMG, I'm not exactly sure. Like, do you have the full name, or is
Diffuse midline
Oh,
glioma.
okay, got it. Okay, so there, even within the diffuse midline glioma category, there's like some that have mutations in H3, F3A. It's like a K27M mutation.
That's what I have.
Yeah, so that's different. That's in the new WHO book, the new book that came out in the new Pathology Bible that came out in 2021. There's a whole new category that this tumor now exists. It didn't exist actually in 2018 when you originally died. There was no diffuse midline glioma H3, F3A, K27 mutant. That didn't exist. It's only in 2021 it now exists as a recognized entity. And so that's, I think, one thing that's different. So because, in the old days, which was not too long ago, we would just say, oh, it's a glioma or it's a GBM. It's like, but everything kind of looks the same at some point under the microscope. So you need to kind of go beyond that. But we didn't have technologies, right? We didn't have sequencing. We didn't have methylation. These things didn't exist. So as they come into existence and we start applying them, we're like, whoa, all these glioma GBMs that I thought were GBMs are actually these are the GBMs and these are something else. And then we got to figure out what it is. because those patients behave differently. They respond to treatment differently. And we didn't know that in 2018, but today somebody diagnosed with the same exact tumor would be diagnosed with a diffuse midline glioma right now, today, up front, and they would be probably managed differently right from the start. So the field is literally evolving in just like the last couple of years for you.
Yeah, that my doctor had said that the definitions, I guess, changed, and that changed my diagnosis. But do I still have glioblastoma, or should I be saying I have diffuse midline glioma?
To call something a glioblastoma, there's a very specific definition, and you no longer fit that definition. You have a new entity that was created for patients that have exactly the type of tumor you have. It's generally in the midline, it's sort of diffusely infiltrating, and it's got this one specific mutation. That is what you have now.
Okay.
That is, the GBM, all these things may have been called GBMs because we didn't have another name for it. But in the 2021 book, it came out, like, we recognize this as a new type of tumor. And so, believe it or not, like, we're still sort of naming new brain tumors going forward. I wouldn't be surprised in the next iteration of the book, there will be new types of brain tumors that are named. And again, we just keep sort of teasing it out from this sort of general diagnosis to more and more and more and more specific. Specific to that patient's tumor, specific to their molecular profile. That's the goal, so that we aren't sort of lumping patients into sort of these generic categories like in the old days.
Oh, thank you.
Okay, so-
Quickly, we do want to include some of the questions that have been asked by our attendees that are virtual, and I believe that some of them have been answered within what you've said, and so the ones that I think have been answered, I'm just going to read them, and then if there's any part of their question that you know that you didn't go into, then you can address that part. You do not have to repeat.
Okay, sure.
But some of the question was, one was, can you address necrosis within a glioblastoma and the implications of it? The one that more so on what you were just speaking to, how do you think about mutations? Are there keys to unlocking treatments? So, and you just shared, we have a new brain tumor type. And what does it mean when they say methylation is detected?
Okay, yeah.
I believe somewhere you've touched on those three already.
Yeah, and you typically hear methylation for the first time in your life when you hear about MGMT. That's the first time it comes up. So let's do necrosis. So necrosis and along with microvascular proliferation and mitoses are high-grade features. So if I'm looking at an H&E of just what looks like an infiltrating glioma, and I don't see necrosis, and I don't see mitoses, and I don't see microvascular proliferation, this is a low-grade glioma. I think generally speaking, if I see mitoses, I go from a grade 2 to a grade 3. If I see mitoses plus vascular proliferation or mitoses plus necrosis, I go from a grade 3 to a grade 4. That's typically the way we've been doing it historically. It's a little nuanced these days, but for the most part, those are high-grade features and tells you something about the tumor and how it's behaving and the aggressivity of the tumor. And so these are the hallmarks of a glioblastoma. It's mitotic activity, microvascular proliferation, and necrosis. You see these very commonly in GBMs. Mutational profiling is important because you can have a tumor that looks like this here, but it can have 10 different molecular sort of subtypes, right? There are some that have the H3F3A K27 mutation, some will be BRAF mutated, some will be EGFR amplified. They all kind of look the same under the microscope. So that's you have to kind of go beyond that to subtype these things more. And then even some of them will have targetable alterations like NTRK fusions or RET fusions or not ROS fusions that can have very specific therapies related to how you would treat that patient. So that's why the molecular profiling is important. One, it helps you to diagnose, make sure you got the correct diagnosis in the first place, because you can't have an oligodendroglioma really without 1p19q code deletion. So if you try to do that, like somebody like me would get that and say, this person misdiagnosed the patient. We got to fix this one. Or maybe now in by the time they've been living for so long that which is great news, but now we understand why, because the tumor, we know more about that tumor in the molecular profile today than we did 15 years ago, right? Things like that. Methylation, it's about the MGMT gene. It's like one of these genes that are involved in repairing the DNA. And methylation is sort of like think of it as like an on and off switch. If the gene is methylated, it means it's kind of like turned off. So the methylation comes in and like blocks the gene from working. And because of that, it can't fix, the gene isn't working, so it doesn't make the protein that fixes the damage. And so that's why when it's methylated, you're more likely to respond to therapy with temozolomide because the tumor lacks the ability to fix the DNA damage caused by the chemotherapy. But if it's unmethylated, the gene is working good, it's full speed ahead from the MGMT gene, and so any damage you cause, it tries to fix it. You cause the damage, it tries to fix it. So you have less response to things like temodar, temozolomide.
So we've got a tumor that is not fitting any of the
Yep.
things. We're talking unmethylated, was GBM, now pleomorphic astrocytoma, IDH wild type, not fitting any of the particular stereotypes.
Yep.
We have been trying to find, is there a genetic marker that if we were to go precision medicine, immunotherapy, or CAR T cells, we've also done genetic testing. How can we find a marker that needs to be addressed
To be treated.
if there's a recurrence of the same tumor?
Yeah. So this is another example of a tumor that was diagnosed as a GBM. It probably got seen. You're like, it's not behaving like a GBM. It's kind of weird. What's going on here? And then it maybe there's a second biopsy. I looked at it again and said, okay, now we're going to call it a PXA, pleomorphic xanthoastrocytoma, which is another sort of category you're always in your mind trying to think about. Those generally have a BRAF V600E mutation. So that one's negative. So the question is, if they only look for BRAF V600E, did they sequence the whole gene? Because there's V600K, there's V600 indels, there's all these different types of things. You got to have a full BRAF workup. And then there's other genes that could be involved. And so that's where sometimes, like in the old days, you would you'll sequence 1 or 2 genes. Now, most of the time, you should try to sequence an exome or 500 genes or 600 genes or something large. And so that you cover as many genes as you can because all these tumors, they don't read the book. They don't know they're supposed to have a V600E or this one wants to be different. And now you're stuck with the diagnosis of a PXA that doesn't have the standard typical biomarker. That's kind of weird. But the question is how complete, I always say, was the workup. And despite all we do, we could even do whole genome sequencing. Sometimes we still find tumors where we are left with just the H&E diagnosis because it doesn't have something, right? In 20 years, maybe we'll know, but as of right now, we don't know. But I think that would be my recommendation is how complete was all the testing? And did you have a good review of that? Because sometimes that could be a gap. If it's too focused of testing, you're going to miss stuff. And so you need to be broader. And that's sort of the general consensus these days is more the better in terms of sequencing.
And we're getting close to the 5-minute marker before the actual entire session is over, so a couple of more questions in here.
So I did have a gene panel done.
Yep.
And how do we interpret pathogenic versus likely pathogenic? What does that mean?
So pathogenic, so you could sort of think of, like you could sequence a tumor and you'll find, you could sequence normal, you could sequence me, I'm mostly normal, I think, and then you'll find variants. And there's question is, does it mean anything, right? Is it pathogenic? Is it likely pathogenic? Or is it just sort of a normal like variation in humans? Like you can sequence different populations of humans all over the world and you'll find different things. It doesn't mean anything, right? It's just we're all a little bit different. And that's perfectly fine. So there's benign. We know this is totally normal. If you sequence 5,000 European people, you'll find this at this percentage. If you sequence 5,000 Asian people, you'll find the same variant at a much lower percentage. But they'll have something different. So those are benign sort of things. There are variants or mutations called VUS, variants of unknown significance, where we don't know what it is, actually. We don't think it has any effect. We've sequenced thousands and thousands and thousands of tumors to date collectively, and this one doesn't really show up often, and it doesn't seem to be linked to anything. So you'll see that under a category of a VUS on your report. Then there's pathogenic, where we're like a BRAF V600E. That's like, nobody's arguing. the whole universe agrees this is a pathogenic mutation. It's causing, it's driving, it's doing something. It may even be targetable with an agent. And then there's the likely pathogenic where the evidence is there, but it's not quite as strong as, I would say, a pathogenic variant. But it's likely there. So it's just a matter of more evidence. What if we put this into a cell line, or what if we put that mutation into a mouse? Would the mouse generate a tumor? Would it cause the mouse to have a tumor? That's kind of how we think about some of these things. But as more evidence builds over time, some of these things will move into the pathogenic category, or some of these things might move out of the pathogenic category, right? So I think that's, or the likely pathogenic category. And so that's how we think about these. But that's, again, another discussion. You can always talk to your molecular pathologist, or genetic counselors are really good at this stuff too. They're really smart. They have a good way of explaining this stuff as well. And you can see if it's changed over time, right? Just because you had a report from 10 years ago, the same variants may have been more things associated with it today because of more information.
Thank you. I have a two-part question,
Yep.
if you have time for
Sure,
it.
yeah.
Going back to the tumor, the high-grade, the rare brain tumor, most closely resembling a glioblastoma, that was put in the possible the HPAP category by the WHO classification, that was then changed to a possible circumscribed astrocytic glioma. We were told that the fact that a tumor was circumscribed does make a difference in the diagnosis. As far as the prognosis, could you just comment on how that could make a difference, even if you have all the high-grade features, and the fact that, how do you work with the surgical team to determine if something was determined to be possibly circumscribed, and how does that play into your findings?
Yeah. So the way the tumor is circumscribed, meaning like when you look at it on imaging, it's like really, it's more like sort of like tight borders rather than a typical glioma, which is infiltrating, which you can kind of think it's like dense tumor, and it kind of gets thinner and thinner, like there's less tumor as you go out, but there's always probably some tumor around the cavity and things like that. Now, circumscribed means it's probably not so infiltrative, and some tumors, like a PXA and others, will grow in that pattern, and you're like, wait, this is weird, like why would a GBM be so circumscribed? Usually they're very infiltrating and sort of are kind of single cells infiltrating everywhere. So the idea is that you can imagine the surgical team, they're going in there to resect this thing, and the more sort of like self-contained it is, the better you are able to get around it and cut out more of it. So you probably have a better gross total resection because of the way the tumor is growing in the brain. If it's one of these sort of diffusely infiltrating things, they're going to kind of cut out the core of it, but there's always the stuff around the edges. And so when the radiation oncologist goes to sort of treat that patient, they're not just treating like right around the cavity, they usually draw a little bit of a zone around it because they know there's some of these sneaky infiltrating tumor cells in and around the cavity. So that's where maybe the circumscribed nature of the tumor tells you it's probably, it doesn't look like the typical GBM, and under the microscope, we can, sometimes when they take out the tumor, there's adjacent brain tissue. So I could see the border between the tumor and the adjacent brain tissue on the glass slide. And I can say, oh, this is kind of weird. It's like really, it's like there's like a line you can draw there, which is kind of odd for most infiltrating gliomas.
So you can actually see that line, and do you factor that into your determination as to whether it's high grade, low grade?
No, the grading is all based on these features.
Yeah.
Right. But what I would do is write a note saying, in my note, I'll say, hey, this tumor is very well circumscribed. It doesn't have that infiltrating border. But remember, like when the tumor comes out, it's like always in fragments. It's not like it comes out in one big ball. They're like kind of pulling out pieces of it. So you don't really quite get like a golf ball that came out and you're kind of tracking around it. So you see areas where parts of it are sort of abutting the brain tissue, and you can make descriptions like, hey, this seems more circumscribed. The morphology seems a little funky for like a typical GBM. And a tumor board, the imaging will show it, and then I'll say, hey, in my report, I also noted that when it was growing in the brain, it kind of had like a really odd growth pattern. It wasn't sort of diffusely spreading. It was kind of tight. And so we'll say like, oh, that's uncommon for a GBM. And so, well, what does the molecular features look like? And that's how we would work it up.
Thank you.
Okay.
We have one more virtual
let's do it.
question
Yeah,
that's
please.
actually been asked by multiple people,
Yeah.
and I believe you also touched on it briefly, but the main question is, and the audience more so are survivors like myself has had a meningioma or just a benign tumor where none of this information was provided in a report form.
Yeah.
And they've also shared that because of the nature of the situation, when you get a brain tumor diagnosis, time is of the essence.
Yeah.
Everything's fast, surgery. So I've heard you say for specifically possibly malignant tumors to go to the oncologist and go to the pathologist,
Yeah.
So for our benign tumor patients and survivors, is that our neurosurgeon? Is it in my chart, or
So-
what is our first step? Because like about 10 people have asked
Yeah,
that.
it's typically the same thing. I always point everybody back to your neuro-oncologist. They are your quarterback, the captain of your team, whatever you want to call it. They are your point person. And if there's a question about, do I need molecular testing, they're depending on how they practice, the answer is typically they're biased towards it. But it's got to make sense because there's sometimes a bill associated with it, so we don't want to do testing that is going to cost a lot of money that if it's not really adding value. For example, if you have a grade 1 meningioma that's pretty well resected and the plan is to kind of just follow up on imaging, do I need to do more complex testing on that meningioma? Maybe not, right? Because the question is, I could do all the testing in the universe, but is it going to change the way your doc manages you? And if the answer is no, then we could do a lot of testing, but it's just not going to impact how you get treated. So we want to be mindful about doing things that are going to add value to you as a patient and your oncologist, so you can make the best decisions.
So is it would we say that having our brain tumor report is not viewed as beneficial?
No,
Because that's
I
more
think
so
you
the question. They were like, how do we get it? And we've
Yeah,
never
oh yeah.
seen it.
I think typically it should be, all your pathology reports are typically in your chart, and sometimes it's a little tricky for us because we will issue a report on a weekend, and then it shows up in the patient's record, and now they're not seeing their oncologist for 3 days, and now they're like, what is this GLblastoma thing? And it's it could be a little bit of a problematic thing. But it should be in the chart, and if it's not there, it's probably just because it hasn't been done.
See, okay, so that's good to know. So
Yeah.
that answered about 10 of the questions within the virtual space. We have come to the end of this session. Dr. Ramkissoon, thank you so much.
Yeah.
Let's give him a round of applause. This has been very, very valuable information, and I know we will all agree with that. So we are now getting ready to go into another short break. There are snacks and beverages, just a quick refresher out in the exhibit hallway. And there's also the relaxation lounge. So if anybody needs an actual physical, emotional, mental break, please take it. There are actual spaces separate for that. So please check those out. And also the exhibit booths. If you haven't been to all of those yet, this is the time to do that. And do not forget to get your name badge scanned. How many people have gotten it scanned? You don't know to get it scanned? Look, okay, you got maybe that's our fault. So you have a little QR code on your name badge, and it's like a passport to kind of show what you've done for today. So make sure you get it scanned to be a part of that contest. Now, I'll tell you right now, I have no clue what the prizes are, so you can't ask me and I can't tell you, but there are prizes. It is a contest, and we will reconvene in Utopia Ballroom at 2:15 for the rest of the program. And virtual attendees, please go to your agenda online or in the Hoover app to see what you are to do next. And again, thank you so much.